So welcome again, everybody, to this special presentation. I'm going to turn it over to our fabulous speaker, Kelly Lundenberg, let her introduce herself. And if you guys have any questions, be sure to put them in the chat. We'll be having some time to answer them at the end. Take it away, Miss Kelly.
All right. Hi, everybody. My name is Kelly Lundenberg. I have been friends with Beth for years, probably, I don't know. We gotta date ourselves, maybe 25 years now, and have served on the board for the Autism Society since then. I'm also an occupational therapy assistant and work in the Reach Autism program, as well as just finished my credential for assistive technology. But most importantly, I'm an adult with autism. That really taught me more than anything school would teach me. So, tonight I'm just going to help you kind of understand really what is autism, like what does it mean? What are the strengths and weaknesses? And really, where do you go from there, right? Let's see. So let's just go over some brief facts before we get into the actual diagnosis. So we know currently that 1 in 36 children is diagnosed with autism, and 1 in 22 in California currently. And that actually is a statistic for children. They really track children in school as far as diagnosis, and so that's how we get that information. We know that autism affects all races and socioeconomic levels. When originally when autism was first coined, they thought it was a disorder that commonly only white upper class families experience. But what we know now is those are the families that just had access to these high levels of doctors that were just beginning to label and describe what autism was. That really, it doesn't, all people are affected with autism. It's diagnosed more often in males than females, and we'll go into that in a little bit, but it may or may not be more common in males. We're still looking at it and trying to discover what's happening with that. We know that it's caused by a combination of genetics and environment, but we don't exactly know what the exact cause is yet. There's some studies that say, 1% this and 2% that, and it's different, correlations to autism, but nothing definitive that says, all people with autism, it's because of this. We know that people with autism have different, brain structures, but nothing exact for everybody at this point. So there's no known cure for it. We do know from research that early intervention and therapies assist with developing skills for independence, and that somebody lives with autism throughout their lifespan. So autism is a spectrum. I'm sure you guys have heard that in the media, but really, what does that mean? It means that no two people with autism are the same. We have different strengths, different weaknesses, different ways of communicating, different sensory issues, and different learning styles. So, for example, I'm obviously very verbal at this point, but I still have extreme difficulty with sensory issues. And we'll talk about sensory issues later down the road. And I was able to get through college with some support later some support earlier in my life, and then independently as I got older. There are also some very verbal people with autism who still are unable to, get a high school diploma, who may need more help with some life skills. And then, I used to run a social group for people who were non-speaking that used devices to communicate. Some of them were completely nonverbal, yet had bachelor's and master's degrees, had written books of poetry, and became very high-level professionals. So it really is a spectrum. You really don't know the future. You don't know what to expect, because we really do have such different profiles. So, diagnosis, right? This is something that people often have a hard time with. So, first of all, there's a medical diagnosis. A medical professional will use what we call the Diagnostic Statistical Manual, the DSM. It's in its 5th edition, to look at a group of characteristics to see if somebody qualifies for a medical diagnosis of autism. And this diagnosis is provided by a medical professional. So a doctor, a psychologist, neuropsychologist, neurologist, or psychiatrist, right? So those are your main people that are going to diagnose the medical autism. You'll also, as you go through the different systems, have assessments for specific systems. So, if you're an adult and needing some assistance getting a job, you might apply to the Department of Rehabilitation, right? And they'll do a screening and assessment to see what you need help with, for their agency, right? That doesn't mean you have a medical diagnosis. It just means that you're qualifying with them, right? Same thing with the educational system. So you might be going into the educational system, and we do what's called an assessment early on, an initial assessment. So a kid might come in with a medical diagnosis, right? Their doctor says, absolutely, this kid has autism. Well, the school may look at the child and say, well, yes, they have a medical diagnosis of autism. However, they're functioning completely, typically, like their social skills aren't affecting their learning, their sensory systems aren't affecting their learning, their behavior isn't affecting the learning. So at this point, maybe we don't qualify them for an IEP or a 504, right? So we also have kids that will qualify for an educational diagnosis, or not diagnosis, label of autism, right? But they don't qualify medically. So it can go vice versa. And then we also have Regional Center, which is a common agency we use down in California. And so they'll do an assessment and see if you qualify for their services. So we also have people that qualify medically for autism, but don't qualify for regional centers in our location, based on their particular assessment. So I hope that helps kind of identify some of those differences. So again, we're looking at the medical diagnosis of autism. So using the DSM, that medical book for diagnosing medically, right? So in the DSM, it says that there are 2 main areas that you have to qualify in, right? You have to have difficulties with social communication. And I'll go into it a little bit more, but the general overseeing definition is persistent deficits in social communication and social interaction across multiple contexts. So, right, so it can't just be that, oh, maybe at home they're not communicating very well, but at school they're communicating, and at the babysitters they're communicating, and at church they're communicating. So it has to be consistent across all these different environments that these issues are happening, right? There's also difficulty with behavior, right? So the overseeing description says restricted, repetitive patterns of behavior, interest, or activities. And we'll go into that a little bit further. So there's 4 areas, but you have to have 2 of the areas in order to qualify for the medical diagnosis of autism. And then once they've determined that, yes, you met all these social and communication definitions and all these behavioral definitions, then we'll say, okay, well, what level is this person needing? What kind of level of support are they needing? So are they a level 3 requiring very substantial support, a level 2 requiring substantial support, or a level 1 requiring support? So you may get your diagnosis back from a medical professional and it could say autism level 1. Sometimes it's one number, or sometimes there's two numbers. It could say autism spectrum disorder 3,2, meaning they require very substantial support for social communication, but only if it's a 2 for the second number, requires substantial support for behavior. Like they don't need as much support in their behavior area. Okay. So often doctors will only give one of the numbers, but if you see 2, it's referring to the different categories. So social communication. Remember, that's your first category. And in the social communication category, we need all 3 of the following slides. We need all 3 of them to qualify for the medical diagnosis of autism, right? So the first one, the first of the 3, is differences in social emotional reciprocity. And then here's some examples that the DSM gives. Back and forth conversations, right? So for me personally, I had to learn how to have back and forth conversations. And here's an example I always give. Like I would come in, early when I got hired at work, and one of my coworkers would show me her nails and say, "Oh, look, I got my nails done." Well, the color of nails wasn't interesting to me, so I'd be like, "Oh," and then just walk away. I wouldn't ask her anything. I wouldn't ask her how her weekend was. I wouldn't say, "Where did you get done?" I wouldn't say, "Oh, it was nice," right? Because to me, nail polish wasn't interesting. And what I had to learn was to have the back and forth, like ask her about her weekend, ask her about like what she likes, because then we would talk about what I liked next, right? So I had to learn that back and forth conversation. Like she would say, "Oh, how was your, how was your weekend?" And I'd be like, "Fine." And she's like, "What?" And then she would teach me like, "Oh, how do you have to expand, right? You don't just say fine, like say like one thing you did this weekend. "Oh, well, we watched movies." And then I'd be like, "Okay, we watched movies." And then, after I had that down, she would have to say, "Okay, now ask me how my weekend was." And so I would say, so then the sequence would go, she would ask me, "How's your weekend?" And I'd say, "Fine." And then I'd be able to label one thing I did, right? And then I had to learn like, "Oh, how was your weekend?" And then she would teach me, okay, once she said something about her weekend, I had to say either nice or ask a question regarding what she did. So I had to really learn that back and forth conversation, right? And it could be sharing of interest, right? It could be like when I was a kid, I really loved this, what it was called a handy Andy tool set. So it was just this little toolbox, a kid's toolbox with all of these different tools. And, I would take them out and, line them up and everything. But, if somebody was like, "Oh, what's that?" I wouldn't point it out to, I wouldn't hold it up to them. I wouldn't show them. I just didn't really share my interest with them. Right. And then sharing of emotions, right? So I'd get back from a trip and they would say, "How's your trip?" And I would just shrug or say, "Fine." Even if it was the best trip I ever had, even if I was elated about the experience, I wouldn't say anything. I wouldn't share that emotion with my family. And you'll often see this in toddlers. One of the first things that toddlers do before they even are talking too much is, if they're they find a little book and they'll bring it up to you to share. They want to share that emotion, share that interest with you, right? So that's where when you see the early signs and symptoms of autism, like if kids aren't like, bringing the toy to you, if they're not like using what we call like joint attention, like looking at something and looking it back at you, so you guys are sharing that emotion experience, that is often a characteristic of autism. So the second one, remember, we just went over the first area of social communication. The second one is difficulty with nonverbal communicative behaviors used for social interaction. So remember, just like we were talking about with the toddler, like looking at something and looking back at you, along with that, they often don't like point, right? They're not like pointing and making eye contact to show you the bird that's in the sky across the water, right? They're not often like looking at you and looking back. A more verbal individual may have a lot of verbal interaction with you, but may not use their nonverbal cues. Like they may not be using their hands to talk, and they may not be using their body to tell you that they're getting ready to leave. One of the things I frequently talk about is how most people know you're about to leave because you see somebody gathering their purse, and their feet are facing the door, and their shoulders kind of turn this way like they're going to leave. Well, I didn't notice all those things when I was younger. So it often was like I was talking to somebody and then they walked away because I didn't see those things happening. And because and we'll talk about sensory in a little bit, but because I have a hard time using my personal body, like I didn't often use those social cues either. So often, my mom would say like, "Oh, aren't you happy?" But I just looked neutral. Like my face wasn't showing how my emotion was all the time, right? Sometimes I was actually pretty angry, but my face looked like content, right? So my body and face didn't often match how I was feeling. So the third area of the three of social communication is developing and maintaining and understanding relationships. So the first example they give is difficulties adjusting their behavior to suit various social contexts. So that's, we all have to change our behavior a little bit. When you go to work, for example, you're not cussing at your boss, right? When you go to Disneyland, you may be jumping up and down, and it would be quite odd if you were there in a suit and very formal and not smiling. So we all kind of adjust our behavior in social context, but people with autism often don't. We don't really adjust. We're kind of the same wherever we're at, right? It doesn't matter if you're in church, like if you act the same wherever you're at, even if it's not necessarily appropriate for that situation. So one example I could tell you is one time early on in my, conference years, so I was probably like 16 or 18 years old. I went to this gala for autism. Well, I mean, it was a conference, sorry. It was a conference, but they also had a gala at night. I chose not to go to the gala, but then ended up going swimming with a friend of mine, right? And after we got out of the pool, we were just playing around, and I started running away from him, and I ran with my wet bathing suit into the gala, across the gala floor, and didn't see that was inappropriate for that situation, right? And then difficulties in sharing imaginative play or making friends. So some people on the spectrum have an intense imagination, but they don't really share it with other people, right? It's their script, their world, their play, right? Or they may have difficulty in making friends. So for me, I was like actually the opposite. I did not have a good imagination at all. I was very factual. And oops, sorry. In fact, I remember one time my sister had one of those like toy microphones that she was recording me when we were a kid. I think it was like the Home Alone like one. And she was all excited to use it and came up to me. We just gotten it for Christmas, and she's like, "Pretend you're Santa." I could hear her like whisper to me in the background, and I was like, she's like, "Santa." what are you doing? What do you have to say for yourself, or something like that? And then I didn't know what to say. So she was like, I could hear her whisper, say ho, ho, ho. And so I'd be like, ho, ho, ho. So I just like wasn't able to come up with imaginative play very easily. And I really had a hard time making friends because I really thought kids playing was kind of dumb. Like I was like, that doesn't make sense. Like that's too chaotic, and why go play those dumb games when you can like go research about China, you know? So then we'll talk about that in a little bit. But yeah, so I had a really hard time making friends because I couldn't join in their games and play those imaginative things with them. So another thing that it caused difficulty with was because I was a very literal and logical person. So if you said something was blue and it was actually yellow in your pretend game, I would say, no, that's not yellow, it's blue. And I'd get very upset and mad in it because I was being literal and thought, oh, that is blue. Why would you say it's yellow? Right. And it says appears to lack interest in peers. And I would say it heavy emphasis on appears, because most people on the spectrum have interest in peers. It's just very hard for us to engage. It's confusing. But the majority of us do want friends, right? It's we're often labeled as like not liking people or not liking interaction. We do. It's a lot of work for us. Okay. So behavior. Remember, this is the second category of the DSM. They had the social communication, now the behavior. So the next 4 slides are the next 4 possible characteristics you can be used to be diagnosed with. So you only have to have 2 of these 4 to be considered for a medical diagnosis. So it's not that everybody with autism has all 4 of these. You just have to have 2 out of the 4, okay? So the first definition they give is stereotyped or repetitive motor movements, use of objects, speech. Okay, so we're going to go into some of these examples. So a lot of times when you're talking about autism, you'll hear people say, oh, he's stimming, or oh, is that a stim? Well, stimming is what we call a self-stimulatory behavior. That's the actual the stimming is the slang for that. And it's basically what we call a repetitive, non-functional, even though it is functional, but that's the definition for it, behavior, right? So it could be rocking back and forth or side to side, right? It could be flapping your hands or twirling your hair, clapping your hands. Even neurotypical people stim, right? They'll chew on pens or shake their leg. These are things that our nervous system does automatically, and either to alert or calm our body. So that is one possible repetitive behavior you can have in this stereotyped movement. They use echolalia in this category. So echolalia is actually the repetition of words or what you hear, right? So if I was a 5-year-old little kid and had echolalia, my mom would say, do you want some? And I would say, want some? Or what is this? And I'd say, this, rather than answering the question, right? Or do you want a cookie? And then I would say cookie rather than yes or no, right? And it could also be kind of what we call delayed. So it might not be right that second, but that gets into more of the scripting, your third bullet point down. So delayed echolalia is basically scripting. And scripting is like taking language from what you heard language or sounds that you have heard earlier and using them more in an elaborate way, right? So one example I always give is when I was a kid, and I used to love the movie Mary Poppins. And so in that, the little boy, had been watching Mary Poppins and said, "I told you she was tricky." So I would take that script, I memorized it like this little YouTube video in my mind, right? So I'd be like, "Okay, I told you she was tricky." So sometimes I would just say it, or sometimes I would say it with meaning, like, say, for example, I say, for example, I was upset with my sister for doing something, but I didn't have the language or the words to, you know, tell somebody that, right? So instead of saying nothing because I didn't have anything to say about that, I would say, "I told you she was tricky," even though it was a little bit out of context, a little bit weird, but I would use that scripting. Or sometimes I would, hear parts from a movie and I would just be like, saying them in my mind, and it didn't necessarily mean something. So you'll hear some kids that'll completely, they'll recite an entire movie because they have it down in their mind, right? So idiosyncratic phrases. So with this, what's a good example? When I was a kid, I would want to interact with my mom, right? But I didn't have like the back and forth conversation yet. So I did have a few phrases. Like, so if I wanted to engage with her, or I became anxious and just wanted to talk to her, I would say, "Hi, how are you? What's your name? Hi, how are you? What's your name?" And like literally like every 30 seconds, "Hi, how are you? What's your name?" And I'd keep asking her over and over and over. Even though she was my mom, I knew her name and I knew how she was. She just said so, but I just had this repetitive phrase that I would use over and over and over because I didn't have the conversational skills to talk about something else. But I wanted to play with her. I wanted to engage with her. So I would use that. And then another common thing you see is either lining up toys or flipping through objects. Or, a lot of my kids that I work with will take like a string and flick it in front of their eyes. It may look like somebody in college that really has to organize their book from like tallest to shortest, and it needs to be in that order, right? It's just very repetitive and very organized and controlled, right? So the second part, so remember that was just behavior 1, that slide we just went through. This is behavior 2. So insistence on sameness, which could be inflexible adherence to routines or ritualized patterns of verbal or nonverbal behaviors. So, so it could be something like distress at small changes. Maybe, when I was a kid, I would always use the blue cup, right? And my sister would use the pink cup. And, the one day that the blue cup was either dirty or missing, my mom hands me a pink cup and I like wouldn't be able to handle it. I drop to the ground and cry and become very distressed because that wasn't the cup I used. It could be that even still, like I'll go into the office and I always sit in the same chair. And if it's, my seat is taken, and then I become very anxious and have a hard time with it, which is better because 10 years ago, if somebody was sitting in my chair, I'd scream and possibly hit them, So they're really, it seems small at the time, but that was the one thing that kind of was like organizing my life and that I depended on that didn't change in my life. And we don't have a lot of time to go into like sensory and kind of my personal experience, but we crave a lot of the sameness because a lot of the rest of the world is very chaotic. So difficulties with transitions. So I remember, going to school, and usually we went to the left, we got to the end of the street and turned left, and then we would turn right. And I had this whole thing planned in my mind. I'm like, okay, we're going to go through this speed bump and we're going to turn left. And I thought I knew what was happening. And then we would get to the end of the street and turn right. And then I would start like screaming and kicking the back of the chair. Right. It could be, now what it would look like is, say for example, if I'm doing something on the computer and somebody's like, oh, come on. And I'm like, oh, hold on, I have to finish first. And I get anxious if I have to transition without completing what I was doing. And then very rigid thinking patterns. So we have a hard time often thinking more abstractly. So I was like this with rules for sure. So say for example, we were crossing the street and I had learned like, oh, you have to cross at the crosswalk. And say my family was holding my hand and trying to cross the street. Maybe it was like 5 blocks down from a crosswalk. Maybe, it was a 10-minute walk to a crosswalk. But I would just like, fall down in the middle of the street because I was like, no, you can't cross here. It's not a crosswalk. Or I remember when I was probably about 14 or 15, my sister and I went with some of her friends to the movies. And they really wanted to see this rated R movie, but we were too young to get those tickets. So we bought tickets for some other movie, right? And then her and her friends were like sneaking into the rated R movie instead of the one we bought tickets for. And I was like, no, we didn't buy those tickets. That's wrong. And I like fell to the ground and was screaming and I refused to go in there because it was, in my mind, we were going to the other movie and I couldn't shift my mind over to the other thing and break a rule for that. So like greeting rituals might be the same. So I actually still have like when I say hi to somebody, very often I go up and shake their hand. But if I don't, I get anxiety, right? Even if it's not really a shaking hand type of situation, even if it's a more casual situation, I am like, okay. So one of the little boys I work with, every time he sees me, he has to come and rub my earlobe. So it could be some ritual or a greeting that you do, but in an inflexible way, like you do it all the time, even when it's not called for. And then kind of like I was talking about the street earlier, you need to take the same route or eat the same foods every day. So one thing I haven't really talked about is that behavior 1 and 2, a lot of these examples they give are due to sensory processing difficulties. We'll get to that in a little bit. But the reason why people with autism do a lot of these things is because the world is we're very sensitive to the world, or over or under responsive to sensory stimulation. And we'll get to that in a couple slides. But that's really kind of the reason behind all of these inflexible or rigid types of behaviors. So behavior 3, remember there's 4 of these and we're on 3. So highly restricted, fixated interests that are abnormal in intensity or focus. So it may be strong attachment or preoccupation with unusual objects. So I never had any super strong attachments, but some of my kids will literally, they have to carry this blanket around, or they get super anxious, or they have to carry this particular figurine, or they fall apart, right? So I never had a strong attachment to a particular object, but I was preoccupied with unusual objects. So one of my things that I was really preoccupied when I was a kid was I wanted to know everything about scissors. So I memorized all the, the pinking shears and the regular scissors and the, loop scissors and kid scissors and adult scissors. And I would memorize all these styles and model numbers, right? So that's not quite the usual thing that a kid would get interested in, but that was one of the things that I did. Or it could be excessively circumscribed or perseverative in interests. meaning you basically the same thing. You're just kind of highly focused and very interested in one particular topic, right? So with me, besides the scissors, I would really focus on, for a while I was super interested in researching Chinese adoption. So I knew every like penal code and every law and every step to adopt a baby from China. And this is when I was like 8 or 10 years old. You know, I was really interested in multiple births for a while, and chimpanzees. You know, I have a student right now who's very interested in toilets. So any new building that we go into, they have to go look at the toilet and flush the toilet and see the toilet, right? So it just a very intense interest, basically. So here's behavior 4 of that category of behavior, right? And this is what I was talking about with sensory. We're really actually very happy that this was included in this last DSM because it didn't used to be. But it's actually the thing that people on the spectrum say is our biggest characteristic, and professionals are just kind of getting caught up. Like I was saying, like, you know, I was rigid and inflexible and difficulty with transitioning and all those things because I'm so sensitive to sensory input. So you can be hypersensitive, which means you're too sensitive. It's like the volume on a radio is turned up too loud, right? So sounds are too sensitive, and being touched was too sensitive. Or you can be hyposensitive, meaning your volume is turned way too low, like where you can barely hear like the words. So the definition for this area of behavior is hyper or hyporeactivity. So either you react too much or not enough to sensory input, or unusual interest in sensory aspects of the environment. So some of their examples are indifference to pain or temperature. But this is just an example, right? If you're hypersensitive, it may be that you know, you may touch a kid like this and they're like, oh, or it may be like 1 degree off and they don't want to eat the food anymore because they think it's too hot, right? So it's both ways. It could be hyper too or not enough, right? Adverse response to specific sounds or textures. So, you know, for me, I get super startled with like mechanical sounds. So blenders and vacuums, or sudden sounds like even if somebody drops a pencil, but it's quiet in the room and it's unexpected, I'll still startle and I'll like jump and cover my ears. So I could be very sensitive to textures too. Like I might not like people touching me, or I may hate sticky textures of like glue or mud on me. I'm like, get it off, you know, because it's, and again, this is, I'm reacting stronger than the typical person would, that a neurotypical person would. So excessive smelling or touching of objects, or visual fascination with lights, or movement. So, you know, some people on the spectrum need to move all the time. They're constantly pacing and rocking and bouncing, or some may not like to move at all. They may just like, it may take multiple prompts to get them up and moving. So just the extremes, right? It's too much or too little of all this different sensory information. So we got through all the communication things, right? The social communication things, and we got through all the behavioral characteristics. So after that, in the DSM, it says that you can have all these symptoms, but the symptoms must be present in early childhood, basically. Like when you're a kid or early development, you need to be able to look back, and even though you might not have noticed at the time, you need to be able to be like, oh yeah, I really did line up my rocks all the time, even though it got missed at the time. But those behaviors were there. And there's a note that says they may not fully manifest until social demands exceed limited capacities. So say, for example, you know, you're pretty good with social interaction, right? So you get through preschool fine, you get through elementary school fine, and then puberty hits, right, where dating becomes harder. All of a sudden, because you had the skills to get through, okay, I can play a pretend game, I can play with these things, but then when it comes to dating, that's a little bit more complex, right? Like, does he like me or does he not? Is he playful or not? Is he bullying me or not? Like, and then you might start seeing more of the characteristics because they are unable to meet the social demand anymore, right? Because they can't keep up with their neurotypical peers at this point. It's becoming more confusing and more complex to be able to keep up. So then you might be like, hey, there's some social issues here. And then you can, the doctor might look back at their prior history and be like, oh yeah, they did line up block rocks when they were little. Even though you couldn't see the social aspect, you can still look back and see those things. And then by the time you get to adulthood, it may be masked, which is basically, we all wear a social mask, right? So remember when we were talking about how when you go to work, you're not cussing, and if you go to Disneyland, you're not wearing a suit and being very proper, right? So we all have masks that we use in different scenarios. So people on the spectrum mask just to kind of fit in with neurotypical peers. So we might be like, oh yeah, remember, make eye contact with them. Oh yeah, make sure you stay 10 feet away from them. Make sure you do these. So we learn all these like social rules for all these different situations. And so by the time we're adults, you may not see the autistic side of us as much because we've learned to mask in different situations. And, if you watch other webinars or videos, there's some things about masking and becoming burnt out by it because it's so much effort and work to mask and pretend that you're neurotypical to fit in with that part of your life. So the second note that the DSM says is the symptoms cause clinically significant impairment in social, occupational, or other important areas of functioning. So, say that you have somebody that's a little bit, socially awkward, right? All people have different social awkwardnesses, right? We're all kind of weird a little bit. But if it's not causing you significant impairment in your job, in your dating life, in your friendships, if it's not causing a problem with that, they may say, yes, you have a lot of symptoms, but you have you're completely functioning within all areas of life. So really it's not affecting you too much. So maybe we don't qualify you for the medical diagnosis at this time, right? So that's all the DSM stuff, right? So now I want to go into some more related information in terms that are related to knowing just kind of what autism is. So remember, we were just talking about the DSM-5. This is the DSM-4. So really, I'm not going to talk a lot about this. This was just the addition before it was updated. So in the DSM-4, there was a term called Asperger syndrome, and there was another term called PDD-NOS, which is pervasive developmental, not otherwise specified. So all you need to know that those were originally diagnoses at one time. They're not currently diagnoses, but you'll still meet and hear people that refer to those labels and diagnoses. And basically, Asperger syndrome is kind of your level 1 autism spectrum disorder. And then pervasive developmental, you had many autism characteristics, but not enough to either meet autistic or Asperger syndrome. You had it's not otherwise specified. You're on the spectrum, but it's neither of those two categories, right? So you'll hear those like when you're, watching things or reaching out. Some people that were originally diagnosed with Asperger's syndrome still prefer to use that term, and so you'll still hear them use that term. So females and autism. Remember on the first slide, I said that autism is diagnosed more in boys than girls, right? So what we're starting to look at in research is that females may be misdiagnosed. The original criteria for autism was created after observing a group of boys, right? There were no girls in that observation group. So some of the symptoms and differences in the characteristics were not observed at that time. What we do know is that female brains, even the neurotypical female brain, we tend to be better at social and emotional things, right? We tend to, the stereotype is guys don't talk with their feelings, right? Girls do. And girls tend to be more social, where guys tend to be more hobby related, right? Those are kind of the stereotypes of females. And part in a lot of people that is true, right? So because female brains are more easily picking up the social and emotional information, they may be masking earlier than boys are. So they may not be caught because, they may be figuring out, oh, wait, I need to imitate these other girls in my class. And even though I might not understand the social situation, I'll follow and do what they do because that's what we're supposed to do, right? And then some of the characteristics might be seen as being a girl problem, right? So, in boys, if a boy's, constantly having tantrums, they may say like, oh, what's going on with his behavior, versus if a girl's like, crying and having emotional problems, they just said, oh, she's just an emotional girl, right? So they just put it off as a stereotype. They may say, oh, she's just too sensitive, or, oh, she's just too shy if she's not engaging and interacting, right? So a lot of the characteristics of autism are just seen as dramatic, like girl stereotypes, right? So because of that, a lot of times girls get missed or get later diagnosed. So common strengths, right? Remember, we're all very different. We learn, behave, act differently, but these are common strengths. These not every individual, but this is just the commonality. We tend to have a great rote memory. We tend to be able to memorize facts and repeat them, or we see something once and remember where it is. We tend to really kind of remember things very easily. We can pay attention to detail really easily, if it's especially if we're very interested in it. We might, one of the little boys I work with is very, very fascinated with farm animals and has all these little teeny tiny plastic farm animals, right? But say, for example, just like the one dot of the hoof had like one speck of paint come off in his entire bucket, he could pick it up and be like, oh, and picks it up right away. He is very detail oriented and knows that. Or if you say, for example, a kid lines something up and you pick it up and put it down and you think it's in the perfect spot. No, they may catch it and be like, hey, that's not where I left it. We tend to have a very good visual memory. We tend to be very loyal, truthful. We have a strong work ethic. We're very rule oriented. Remember, I was talking about the crosswalk and the street, and we can be very focused, especially if it's something of interest to us. So speaking of, good rote memories, so we're not all Rain Man. So savant syndrome is demonstrating great aptitude in one skill area, like Rain Man did, right? We see that with Cody Lee, who plays the piano from America's Got Talent. We see that with Jerry Newport, who is able to, be able to tell you the date and day of the week of any time on the calendar back to prehistoric times. So we're not all savants. It says 50% of savants are diagnosed with autism. So of all the savants out there, 50% of us are on the spectrum, but only 1 to 10% of autistic people have a savant skill. So, about, at max 10% of us have savant skill. So it's not the majority of us. It's a minority of us, right, that have these great aptitudes. So some other comorbidities that are very common with autism, having sensory processing differences. Remember, I was talking about it's now become a part of the criteria. If you're interested in looking more into, how to support that or helping to integrate your senses, you can talk to a sensory integration OT, occupational therapist. So, anxiety is very common because remember I was talking about how the world is very, feels very out of control with us because, things are too bright, things are too loud, and many other reasons. So, and learning how to interact with people socially, you have to remember the rules of like, oh, do I say hi? Do I look at them? So there's a lot of things we're having to remember and mask for, creating a lot of anxiety and depression, especially as you reach like teenage and adult years. Obsessive compulsive disorder is common. GI symptoms, pica, which is basically eating non-edible objects. Sleep disorders, other genetic or developmental disorders. For example, a lot of people with Fragile X, which is a genetic disorder, are also diagnosed with autism, and seizures are common. About a third of people on the spectrum are eventually diagnosed with epilepsy. So common therapies, occupational therapy, that's, what I am. Well, I'm an occupational therapy assistant. So we work on the sensory processing, fine motor skills, life skills, self-help skills. Basically, we help kids and adults be able to do what everybody else does. We help them either change their brain so they're not as sensitive to loud sounds, or maybe we kind of compensate and say, oh, those are really loud for you, like maybe we give you some headphones, right? With somebody with a physical disability, we might say, oh, you can't reach your feet, but you need to get your socks on, maybe we use a reacher, right? So we just help you engage in anything that is part of living. Speech therapy. So speech therapists not just work on, actually saying words, but some of the pragmatics and social skills that go with that. So, you're like, oh, my kid talks, I don't need to go to speech therapy, but you're like, wait, they don't really know how to interact. So you still might want to take them to a speech therapist so they can learn some of the rules of engaging with neurotypical peers. That being said, make sure it isn't just about the kid learning how to interact with the neurotypical person, but also teaching neurotypical people how to interact with us, because we often get the burden of learning how to engage with you, but not ever, it's never really taught to, neurotypical people how to interact with us. So then it's twice as much work for us, right? Physical therapy, if you're having a hard time with mobility, related medical treatments, whether it's biomedical treatments or, medications or whatnot. There's play therapies such as floor time, behavioral therapy such as cognitive behavioral therapy or applied behavior analysis. And that's often referred to as ABA, just in case you guys hear that term. So I'm sure if you're new to the community, it's very confusing, right? There's a lot of controversy out there. You read one website that says, wear a hat, and the next one says don't wear a hat, right? You hear one TikTok video that says put on your shoes, and the other says don't put on your shoes. Like, it's there's a lot of things that are very contentious out in our community. It could be on disorder or difference. the neurodiversity movement is really pushing towards, we're really just a variant of normal. Like, there's nothing wrong with us. So we're not disabled. We're just different, right? And then the medical model is more like pathologizing, saying like, oh, this person is broken. They have these criteria. We need to do these therapies and fix them, right? So there's that controversy. And then there's causes. There's been all kinds of theories been out there in the last 50 years of, oh, is it vaccines? Is it caused by refrigerator mothers? Which, if you're not familiar with that term, was they originally said that autism was caused by the mothers because they were cold towards their children, and that was debunked a long time ago. But they, for a while, it was said, oh, it was the flea powder that did it. So there's a lot of controversy over what causes it, and so that's out there. Treatments. So ABA is the more recent one. It's the only really behavioral therapy recommended by the I think the American Pediatrics, American Academy of Pediatrics. I'm pretty sure it's them. But a lot of adults with autism are saying like, oh no, like, this caused me more harm than good. Biomedical treatments can be treated, have been controversial. There's been all kinds of things out there, including like bleach enemas, for a while. And facilitated communication, which is using like tactile cues to help somebody type to communicate. Other controversies are this is another current one, symbols and logos. Currently, the puzzle pieces being kind of in controversy because there's a group of people who are saying, I'm not a puzzle, I'm a person. Stop, using me as being a mystery and something to put together, right? So, that community is like pushing more towards the infinity symbol and the gold infinity symbol, or using gold generally, because if you guys know the periodic table with AU, that's the symbol for gold. And so because of autism, AU and AU for gold, they're like, well, that's our color now, right? Instead of the puzzle piece. And there's also just controversy with systems, right? There's schools, whether you get services or not, and regional centers, whether they should cover you or not, or Department of Rehab, or autism organizations, whether they're meant for good or not, right? So there's just generally what to know. There's a ton out there, probably millions if you look out there. That what to know. There's a lot of controversy out there regarding all these different things in autism. So here are some famous autistic people. Temple Grandin, I don't have a picture of her, but she was the first person with autism to write a book about having autism. So she's kind of a leader in our field. Satoshi Tahari, I think, was the original guy who created Pokemon. Cody Lee, who's the winner of America's Got Talent. Dan Aykroyd, Daryl Hannah, Greta Thunberg, Anthony Hopkins, and Sia. Those are all people who have publicly disclosed that they're diagnosed with autism, okay? And conclusion, ASD is a spectrum, right? Because you or your child or your student are all individuals, you have to do your research and find out what works for you, what works for your situation. More than anything, people on the spectrum, we need support and we need love. We need to be treated as different, not less. Like, just because we have a difference doesn't mean we're less capable, doesn't mean that we're less valuable, and doesn't mean that we don't, need and appreciate all the things in life as a neurotypical person does. Like all people, support our weaknesses, encourage your strengths, and include us. So, a lot of times people focus on our weaknesses, like they're bad at communication and they're bad at, social interaction. So we get put into therapies for 40 hours a week to make us communicate and socialize. However, like if you are bad at calculus, would you really want to be in calculus classes 40 hours a week? No. Like, so yes, support our weaknesses, but don't focus on our weaknesses, right? Encourage our strengths. You can do amazing things, right? And include us. Like we're in all places in the society. Remember, we're 1 in 22 in California right now. So, we're here. So, and then this picture is a picture of Donald T, who is the original, the first case of autism ever to be diagnosed. So he was the first person in medical literature to be described with autism, and he recently passed away last year. So there's a good documentary that was just put out by him. But yeah, so he's an interesting fellow, and he did great, had a great life. And the documentary talks about how really his community supported him and appreciated him and saw how valuable he was, and that made him have a good life. So, all right. So here's some resources. And then do we have time for questions?
We do have time for questions. So if anybody has any questions, feel free to put them in the chat. That's the easiest place. Kelly can check it out. Let me just kind of scan through to make sure. I just want to make sure everybody knows we are recording this, and we will be sending it out no later than Friday. It'll also be available on our website and our video library. Give you guys a chance to type any questions you have. And let poor Miss Liliana take a drink of water. You talked for a long time.
That was a lot of talking.
It was a lot of talking. Feel free to share the link. Once we publish it, we want to get it out there, and especially for our newer families who have a lot of questions. Kelly has experience of coming from a personal perspective and a professional perspective, not to mention her, and thank you for not sharing how old I am and how long we've been friends, Miss Kelly.
Sorry.
Just a long experience. No, you did good. So I was wondering how to find an occupational therapist for adults, because I've been struggling to get occupational therapy as an adult.
Well, we have, I know on our website, there is a resource guide. I believe we have some sensory OTs within that realm. Because you're not in school anymore, obviously. Hopefully you could go through insurance, but you may have to pay out of pocket for that service. But it's always something you could talk to with your provider.
Yeah. Kelly, are you able to stop sharing your presentation so everybody can see? So Kelly, you and I have had this conversation before about adaptive living skills, right? And that in a medical model, frequently insurance is looking for adaptive living skills and not necessarily sensory. Is that correct?
Yeah, unfortunately, that's kind of the direction of things. It depends what you wanted to see the OT for. If it was more like life skills or adaptive skills, you could ask your insurance. You could ask about the sensory. That's a little bit harder to get funded.
Can you give some examples of what like an adaptive living skill would be?
So an adaptive living skill could be teaching you how, it could you could be working on your executive functioning skills, for example, learning how to plan and organize, how to cook a meal, right? So it's teaching you how to make the list, how to go to the store and get all the things you need without, leaving 100 things. come home, being able to prepare it in a way that's organized and not stressful, right? It could be remembering to take your medication every day, or it could be showering or grooming, brushing your teeth. Really anything that what we call is ADLs, activities of daily living, which is kind of like taking care of your body, right? That's your personal body, right? Cleaning and bathing and brushing your teeth and all that. But we also have IADLs, which is being able to take care of the things around your environment, like cooking and cleaning the house and picking up after yourself and driving, right? And unfortunately, a lot of that isn't covered by insurance, especially for autism. But you do have, OTs out there that are out of pocket if you are in that situation to afford that.
And sometimes they can get creative and identify maybe some of the things insurance may or may not pay for. I went ahead and put the list of our resource guide for occupational therapy in the chat as well. Another question: what is the most effective way to facilitate social communication for an adult?
Well, that really depends. So do they have, it really depends. Like, do they have the language skills? They just don't have the social skills to engage. Do they want to engage with others, first of all? That's a big one, because if you're not intrinsically motivated to interact, if you don't want that, then why are you being forced to, right? If you want to, it's hard because some adults with autism may not speak and not have a communication method. So getting a communication system in place. If they speak but just don't have the social back and forth of conversation, very structured environments like game playing, bowling, that have like clear rules beginning and end is a good place to start.
Great idea, thank you. Where do we go for vocational resources for a 19-year-old who gets bored, particularly on weekends? I'm not sure if you meant vocational or recreational resources. So I'll let Deborah chat on that. I think there was another question about, are there resources to help autistic adults get connected to potential employers? Do you want me to take that one, Cal?
Yeah, really, you're kind of going to go around here. It's going to go either two ways. You can be a regional center client and have regional center assist with that. We've really been working like with self-determination and funding, and that's the regional center. Or if you're not qualified as a regional center client, you might want to apply through the Department of Rehab. They will give you, I think, usually about 90 hours of training and help finding a placement, right? But it is hard. It is hard. I'm not gonna lie.
I'm gonna shout out for employment program that we just piloted, and we're hoping to renew at least for regional center clients in some Riverside zip codes, that it is remote training, and at the end there's a career plan, because it's one of the things, and I'm speaking as a parent too, that it really needs to be person-centered. There are absolutely some people that can go out and get any job, right? If you think back to what was your first job, but for some of our adults, they really need a job that they are interested in and that people around them care about them. I think you would agree with that, Kelly, right?
Yeah, I definitely would have not been able to keep my job 20 years ago if I didn't have a very good support network of people like at my employer that just kind of got me, right? I didn't have the social skills, I would often, do inappropriate or aggressive things. And they loved me and didn't, report me, thank God. And I, while I was learning some of those regulation and social things, to be successful. So it really does depend on the place. I used to run our social group for the teens and adults, and we had numerous people with bachelor's and master's degrees who could not find jobs. And it's often goes back to just because they were different, right? And people were nervous giving them a chance.
Yeah.
And that
absolutely.
goes back to, remember, you have to teach the community how to interact with us, not just us how to interact with the community.
And if you're a regional center client, there's more tools that there used to be. So now they have paid internships. Actually, Department of Rehab has paid internships too. So it's also, again, finding employers that have an idea of being open and willing to, care about somebody and learn how to support them, like Kelly was saying. Here's another one. Are you open to talk about your journey of driving and how does sensory work while you're on the road?
That was a big feat for me, actually. I was not interested in driving at all, like not one bit. Keep in mind, this is back when I was in my early 20s, when I still didn't have like the back and forth conversation, right? And I was still terrified of anything new, like any change at all. And my day was ruined. So I would say, what was I, about 21, I think, right? When my sister went off. No, I must have been a little bit, maybe 20. When my sister went to college, and my my sister was driving me to work and she had to leave. So my mom said, okay, you have to get your license. And I was like, no. And I, was crying and having all these meltdowns like for weeks because I was so nervous about it. And, I remember, keep in mind, I'm very, very, very rule bound, right? So I got in the car, and my biggest thing was I didn't want a stranger in the car with me. And because I'm very literal, I had a hard time being criticized. So the fact that a stranger was in the car, like literally checking off things I did wrong or right, like I was like in full panic mode, right? And like I did okay like during the whole driving test. But then when I got back to the DMV, I was so happy to get her out of the car that I turned left into the parking lot without signaling, which is an automatic fail. So that was that. The sensory aspect, it's hard. The first probably 3 years I drove, I couldn't even like listen to the radio, nothing. Like if I drove more than about an hour, I was throwing up because of all the stimulation of it. But really, it was just like slow increments. I still get a migraine if I drive too much, especially if it's, too bright, or if there's too many headlights in my vision. Yeah, so yeah, I have to say it's hard, but with work you can do it.
Right. All right. There's lots of questions. I'm going to try to get through them. Is there a detox recommended for a child?
There's a lot of things out there. I don't know of anything. Biomedical is not my field, so I wouldn't feel comfortable actually recommending anything. So yeah.
I would agree with that. Maybe Taka, who has a little bit more of the biomedical resources, because I don't stay on top of the latest. After going over different diagnoses, you went over the characteristics. Do those characteristics apply to everyone on the spectrum?
So if you remember back at like the slides, there was slide 1, slide 2, slide 3, and then there was probably like 4 or 5 examples. Those are just examples of that characteristic, but it can manifest in different ways than the examples that I shared. To actually receive the diagnosis, you have to, Like when it said like, difficulties with new things, I forgot what the exact terminology was. And then I gave you some examples of new things and difficulty with transitions, difficulty with it. Those are just examples. But you would still have to get that overlying aspect of difficulty with new things, right, from your doctor to qualify for a medical diagnosis. And like with the behavioral ones, remember it was like you had to have 2 out of the 4, and with the social communication, you had to have all 3 areas. But just because you don't have those examples doesn't mean you don't have that characteristic. It just may manifest differently in you.
If we have parents that would like more information beyond the recording, is there someone they can contact? Oh, I could take this one.
Go ahead.
So our fabulous resource specialist, Miss Liliana, is translating. So you met her earlier. And then I know our other fabulous senior resource specialist, Melissa, is also on. So they can call or email the Autism Society. Our resource specialists are parents who have lived experience and are happy to spend. I will tell you, especially as a brand new parent, it's easy to spend an hour on the phone with a resource specialist. So they're happy to walk parents through different systems navigations, as well as helping them find resources that we have, fun family events or other needs that they may need to plug them into the right services that's right for their family. Another question. Great presentation. Can my child be denied services at school even though he has a medical diagnosis? He is now 4 and we're thinking about sending him to a preschool.
Yes, they can be denied. Remember how I was talking about if it's not functionally affecting them in the school setting, if they don't see any support that's needed for that individual in that setting, they can be denied. That being said, if you think that they need you can always ask for an IEE, which is an individual will you talk?
Independent educational evaluation, which basically is a third party who comes in and makes a determination if they qualify. And if you get stuck on something like that, you can call our resource specialist and we can help maybe navigate you through the IEP process, the special education process. And then Zachary, hey, Zachary wants to know, what was the name of the guy who was the first to be diagnosed and what was the year he was diagnosed? Where was he from?
He's from Mississippi. His name is Donald T. That's how they refer to him in medical literature. I don't know, what year was it? Like 50?
50s, let's see. Oh, I was wrong. He was first diagnosed in 1943.
Oh, okay.
Yeah.
Yeah. And if you just put like Donald T documentary, his documentary will come up, and it's actually very interesting. So
yeah, it's Triplett is his last name. Triplettt. Donald Triplett. Let's see if I got them all. We talked about that. As a newly diagnosed adult, I find that I think and or problem solve very slowly. Is that normal? How does one go about addressing this, especially in a fast-paced workplace?
Yeah, that is very common. Different types of processing issues can happen. Like for me, for example, I have a hard time with auditory processing. So if you talk to me too much, or ask me too many things in a row, I can't keep up with it. And then I lose what you're either asking or saying. Especially if it's in a busy environment that's like, a lot of sounds like a restaurant. What you can do is, if you're in the workplace or whatever, you can ask for those accommodations. For whatever processing it may be. It might be that because you It might be, oh, you need to work in a quiet area, or it might be that, oh, hey, instead of like giving me that list by auditory, can you email me that list, right? So you just ask for the accommodations that would make it better for you, depending on what your processing difficulties are.
And that's good, Kelly. Those are really concrete examples of workplace accommodations. So you identified what the issue could be, and then you gave some, and those are usually reasonable accommodations just to make it a little quieter. Some places would let you listen to music on headphones, if it's not too loud where it bother other people. That there's also the it's called JAN, the Job Accommodation Network. I will put that in the chat as well. That has a list of possible accommodations too by diagnosis or issues. So that might be another resource for you. College accommodations. There we go.
Oh, hey, that's Zach. Oh, hey, Zach. I was looking at I saw your last name.
Yeah.
I've seen you in a while.
I was happy to see his name. Oh, any advice for kids with autism and an IEP getting bullied at school? What if the school isn't supportive? I'll let you answer that, Kelly, first, and then we have a toolkit.
Wait, can you say it? Read it again?
Yes, sorry. Very informative information. Any advice for kids with autism and an IEP getting bullied at school? What if the school isn't supportive?
Okay. That's a big question. So, of course you're gonna call the IEP and see like what's actually happening. If the school, is it the school actually admitting there's something happening, or but really what I found most helpful is kids aren't as big of, or the kids don't bully as much if they understand, right? So a lot of times it's teaching kids what's going on, because I'm assuming it's a school age kid. But kids know there's something different, right? But they just don't know why. But as soon as you explain it, as soon as you say like, oh, like I'm using this iPad to speak because my mouth won't use words, then they're like, oh, okay. Or as soon as you say like, oh, I have autism, and you don't even have to say that, I have a hard time knowing rules, that's one thing you can help me with, or something like that. It tends to be better if the kid isn't doing it, if you just teach the people in the environment teach, right? Because a lot of times if the bullied kid tells them that, sometimes it doesn't work. Like that, let's be honest. But it's a really tricky situation, because sometimes it can make it worse and sometimes it can make it better. But your IEP team is responsible for your kids' safety, and if they're not safe, you need to keep don't back down just because they said, oh, it's fine, we'll take care of it. If your kid is being bullied, you need to call another meeting, right? Because safety is priority.
I agree 100%. And I am looking for, last year we published a bullying toolkit that is on our website. It is free of charge, because unfortunately we have a lot of children that are bullied. I'm going to stick that in the chat as well. So,
but I do have to say, kids, if you explain it to them, are much easier to teach than adults are, for sure.
Yes. Yes, and we have some resources and different ways, whether your child is the one that wants to be the one to talk about it, or you as a parent. There's also some books and some videos that could be used. There's a lot of ways to go about it, but I agree with Kelly, as usual. All right, Miss Kelly, we are at our time. I think we got most everything, but thank you so much for taking time this evening and answering all these great questions, this great presentation for our newly diagnosed families and adults on the spectrum. If anybody has any questions, you can feel free to email us at info@ieautism.org, and we would be very happy to talk with you. You're getting thank yous in the chat. So is there
Thanks for
anything else
coming,
you want?
guys.
Yeah. All right, everyone have a great evening and stay safe out there. Take care. Bye-bye.